company of Sugar City FM 90.3. Nor are such statements necessarily supported or endorsed by the owners, managers, or advertisers of the station. While we encourage all to share their opinions, we do not support any comments that may slander, discriminate, or otherwise offend anyone, and we insist that you refrain from any such statements.
Welcome to the Customer Support Portal, where we have made it easier for you to contact us. It starts with your question, email, a message, phone call, or a search on our website. Our CSP provides prompt and efficient solutions to your problems. We pride ourselves on treating our clients responsibly and ensuring your information is kept safe. Log on to www.skndb.net and send us a ticket or email us at customersupport@skndb.com. You may also call us directly at 869-465-2288, extension 1322 or 954-353-1003.
If you have a dream, what are you waiting for? The development bank has what you need and more. We aim to build stronger communities. That's why we have so many opportunities. Business loans, student loans, we make a positive difference in your life, in your life, in your life, in your life, yeah. Financing your dream home, we make a positive difference in your life, in your life, in your life, in your life, yeah. Development Bank of St. Kitts and Nevis. We make a sustained positive difference in your life.
Fellow citizens, near and far, join Newrish Nital on Sugar City 90.3 for Fear No Favor.
Where is man? Where is the gangster man? No runner come out for war.
Tune in to 90.3 on your FM dial. Log on to sugarcityfmstkits.com or download Simple Radio app from the Google Play Store. And join Newrish Nital every Thursday night from 8 to 10 p.m. as Newrish Nital tackles the issues and take your call. Fear No Favor every Thursday night from 8 to 10 p.m. on Sugar City 90.3 FM.
Good evening and welcome to Fear Nor Favor. Tonight we begin a series of health talks with Dr. Natalie Osborne, geared to inform the general public of common surgical diseases. The last time she was here, we spoke about her experience as a surgeon and her background. Essentially, we introduced her to our listening audience. Tonight, we will speak about acute appendicitis, touching on the signs and symptoms, how to make the diagnosis, carry out the treatment, and possibly talk about some complications. Dr. Osborne, welcome back to Fear No Favor on Sugar City.
Good night to our listening audience. Thank you for having me back. I enjoyed my last visit here tremendously, and it is so encouraging that you have asked me to visit back with you. So thank you.
Yes, and I must tell you that I got a lot of feedback from many, many persons. And they were rather impressed with your delivery and the overall show on a whole. They even requested that I try to bring you back as often as possible. So we are going to eventually work out the regularity with which our surgeon, Dr. Natalie Osborne, would be gracing our spaces here at Sugar City. So congratulations, the feedback was tremendous
Thank you.
and encouraging. And when feedback like that comes from certain persons, it is so highly regarded. And it goes to show that people are listening. It is not all the time that persons would call in for whatever reason, because they go and listen. I can recall a person told me that they're listening a show that I did for the very 10th time. So because it's there online, they can go and access it and listen to it as many times as possible. And with this educational, informative, and of course transformative, we expect many persons to re-listen our show. So we got to keep it as a high quality as usual. Now, what is appendicitis, and can anyone get it?
Okay, as we're speaking this evening about acute appendicitis, what you need to know, it is very important that we inform our general public about this very common disease. So first, for you to understand what is acute appendicitis, you must understand the appendix. The appendix is a small pencil-like or tube-like organ that is approximately 10 centimeters in size, an average size, and it is located at the beginning of the large colon. This small organ is located just close to the first portion of the cecum, or the first portion of the large intestine. And it is what we consider a vermiform organ or a vestigial organ that most people believe does not have a function. So we can live without the appendix. Appendicitis usually occurs in the younger age population, around the age of 10 to 30. So that is the age group that are most affected by the acute appendicitis. And in medicine, I would help you to understand any word that you hear itis, you're thinking of there's an infection or inflammation of that organ. So when you hear the word acute appendicitis, it means that a sudden inflammation of the appendix. So itis always suggests an inflammation of the organ. It is more frequent in males than females, all right? And it generally manifests itself within a period of 24 hours. So it's an acute disease, so it happens over a short period of time and progresses very quickly if not treated.
And I was trying to follow from here, but I realized that there was a slight delay. Now, acute as opposed to chronic. Acute would come on to you, as you indicated, within 24 to 48 hours, and it is painful. Whereas the chronic appendicitis can be around for weeks, months, or even years. The impact can linger on for a very, very long time, sometimes even without symptoms.
Lots of literature speaks about a chronic appendicitis, but it is very rare in occurrence, yes. But some persons would have had these pains coming on and off for several months, and then they're later diagnosed with what we may call a chronic appendicitis.
You know, it is interesting because I think that the appendix is delicately referred to as a storeroom for good bacteria for our bodies. So it has some good functions associated with it because it stores bacteria, and that is why, well, I'll leave that for you when you get around that particular angle. But I think it is referred to as well as a storeroom for the good type of bacteria. You know, sometimes they say we have bad bacteria, good bacteria. So it is like a storeroom. Just to elaborate on what you would have said, how common is appendicitis?
We said that we know that appendicitis occurs in approximately 10% of the general population. So if you have a population like ours, we have a small population of what? In our federation, approximately 55,000. So in about 5% of our population, or to 10%, are expected or may be expected to have acute appendicitis in their lifetime. We said earlier it occurs mostly in the young as well, between the age of 10 to 30. It is less common in the very old and the very young. Okay, so you're not see a baby with acute appendicitis.
Okay. You have persons messaging and asking for direct links, and quite a number of persons would have tuned in already.
You made some comments about, and I want to just go back a little to make sure that our audience are clear. Some persons and some literature speak about the appendix as an organ that has lymphoid tissue that may be involved in the immune system. But for all essence and purpose of the organ itself, it doesn't really have a function, and if it is removed, it is not missed, if you understand. It is not missed. Because it is a small tube-like projection from the colon or the intestine.
Okay. What causes acute appendicitis?
Well, acute appendicitis, in any instance, is caused when the lumen or the opening to the appendix, it is blocked by some sort of foreign body. It could be a foreign body, it could be parasites. In the young, we said that it is often blocked by lymphoid tissue, where there is lymphoid hyperplasia. In certain countries where parasites and parasitic diseases are very common, it can be blocked by parasites. It can be blocked by foreign body as well. So it usually begins with a blockage or an obstruction at the entrance to the appendix. And once there is a blockage, because inside the appendix, there is free flow of mucus-like secretions that goes in and out, because the walls of the intestines, the mucosa produces fluid, produces a mucus-like substance. So if there is an obstruction or blockage to the entrance of the appendix, what happens? The appendix then becomes inflamed because the walls continue to produce the mucus-like substance, and it then becomes distended. And as it becomes distended, we have damage or blockage or ischemia of the blood vessels, and then it becomes more distended. And if it continues, the appendix wall can become weakened. It can even go on to perforate. And as the appendix becomes distended, it irritates the nerve that are surrounding it, and that is what gives us the pain.
Excellent. I am wiser within a short period of time. You have made me quite wise with respect to appendicitis. How will someone suspect that they have appendicitis?
Okay, this is, like, I would say, the most important question of the evening, especially for our audience, because this series of a discussion on surgical topics is geared for education. I always do things with a purpose. So once we're done here, I want to ensure that our listening audience have a clear idea. So once they experience any of these symptoms or group of these symptoms, they're prompted to seek medical attention, because early intervention always leads to a better result. So some of the most common signs and symptoms associated with acute appendicitis is starting with the abdominal pain. This is a pain classically, but not all the time, would begin around the periumbilical or by the navel or by the epigastric region, or the area that most people refers to as the stomach area. And then within 4 to 6 hours, this pain moves, or in medicine what we say radiates, down to the right side. In some instances, the patient may have the pain that begins directly in the right side, or the area that we call the right lower quadrant. This also is associated, the patient may have some nausea, like you feel like you want to vomit, or you may vomit and have multiple vomits. You may also lose your appetite. Where you would have normally ate 2 or 3 times in the day, you don't feel like eating. You may eat once, you may take a light, have a light diet, but you realize that your appetite is not the same. Also, the patient can present with fever. You start to feel extra warm when you touch your skin. If you don't have a thermometer, you may feel that you're having chills. The night may be cold, but you're feeling extra cold, and that may indicate that you have a fever. So you may lose your appetite. Some persons, if the disease progresses, you may have diarrhea, you may have abdominal bloating, as we say, or your tummy becomes a little bit heavier or more distended than it normally would be.
Okay. Could we take a break, acknowledge our sponsor, and come back?
Welcome to the customer support portal, where we have made it easier for you to contact us. It starts with your question, email, a message, phone call, or a search on our website. Our CSP provides prompt and efficient solutions to your problems. We pride ourselves on treating our clients responsibly and ensuring your information is kept safe. Log on to www.skndb.net and send us a ticket or email us at customersupport@skndb.com. You may also call us directly at 869-465-2288, extension 1322, or 954-353-1003.
If you have a dream, what are you waiting for? The development bank has what you need and more. We aim to build stronger communities. That's why we have so many opportunities. Business loans, student loans, we make a positive difference in your life, in your life, in your life, in your life. Yeah, financing your dream home. We make a positive difference in your life, in your life, in your life, in your life. Yeah. Development Bank of St. Kitts and Nevis. We make a sustained positive difference in your life.
Fellow citizens, near and far, join Newrish Nital on Sugar Soda 90.3 for Fear No Favor.
Where is the cancer man? No runner come out for war.
Tune in to 90.3 on your FM dial. Log on to sugarcityfmsankits.com or download Simple Radio app from the Google Play Store.
Welcome back to Fear in Our Favor with our surgeon, Dr. Natalie Osborne. Doc, is there any test that can be done to help with or confirm the diagnosis of appendicitis?
Okay. I want to let the audience know that acute appendicitis is what we say in medicine, mostly a clinical diagnosis. That means that you use your evaluation of the patient, asking the question, speaking to the symptoms that we spoke earlier, the abdominal pain, the fever, the nausea, the vomiting, the loss of appetite, the abdominal bloating or the diarrhea. There are also some physical findings when you examine the patient that you're looking for. And that is important that we mention those. So you're examining your patient, as oftentimes patients may be at the hospital. You'll see the doctor expose the abdomen, put the patient to lie flat, and they would touch the abdomen looking for certain signs and symptoms. And some of those signs would include you touching the right lower quadrant to see if there is any tenderness when you palpate or touch. And sometimes you press down, and once you release, the patient will have more pain. That is what we call rebound tenderness. You can also ask the person to cough. Sometimes when the person coughs, because there's irritation of the abdominal wall, you can have tenderness. We may flex the patient right leg, because we're talking about pain in the right lower quadrant, and rotate it in such a way, and in that way we may elicit pain. We call that obturated signs. So there are several different signs that the physician can use along with the complaints that the patients would make to help you come to the conclusion of acute appendicitis. But you ask if there are any tests. Yes, they are. To assist you, we can do several different tests, and we categorize them as such. You can have laboratory tests, where you take a sample of blood and send it to the lab, and you're looking for certain things. One of the more important one, we have the CBC, where we're looking at the blood count. So you're looking to see as well if there is a rise in what we call the white blood cells. That is an indicator that there's an infectious process and the body immune system is responding. So we have what we call a part of the white blood cells, the leukocytes, and that is usually elevated in a bacterial infection. So that is why in the hospital the doctor would ask for some blood to be drawn. You also want to see if the person, you also want to check things like the kidney function test to see how it may indicate that the patient is dehydrated because of the vomits. And if you're going to have to take the patient to the operating room, your kidney function tests are important to see if the person is healthy enough and fit enough for general anesthesia. And along with some of these tests, you want to, as well as helping you to diagnose acute appendicitis, you're also trying to rule out any other pathology at the same time. In a young female in her reproductive years, you may want to get what we call a pregnancy test, because one of the differential diagnoses you have to keep in mind, or one of the disease that may mimic acute appendicitis can be a pregnancy, and something that is that happens very frequently could be what we call an ectopic pregnancy, and that is a life-threatening disease, and you do not want to miss something like that. You can also do things like check the urine to see if there is an infection in the urine, because an infection in the kidney may mimic acute appendicitis. So when you're doing these series of tests, you're also, you're also refuting or discarding different diagnoses to help you to conclude and say in your mind, this is acute appendicitis. So once you've had your blood test, you may be convinced at that time, and especially if your patient is a male, he has very few organs or structure in the right lower quadrant that would give him such intense pain. And it's easier to make a diagnosis of acute appendicitis in a male as compared with the female. But if you're not convinced at this point that it is an acute appendicitis, you can get an ultrasound, an abdominal ultrasound. What will that do? The radiologist will look at the abdomen and see if she can see the appendix. She or her can see the appendix, whether it is inflamed. There's certain signs that they're looking for. And not only you're looking for the appendix in this instance, because sometimes you may not see the appendix, but you're looking to rule out any other pathology. For example, in a female, she may have a cyst on the ovary, and you want to make sure that's not the cause of the pain in the right lower quadrant. She may have what we call a tubal ovarian abscess, where there is an infection in the fallopian tubes. You want to make sure that is not the problem. You can also check with the ultrasound if there's a pathology or problem with the kidneys. You may suspect that there may be a kidney stone, or the kidney has an inflammation or infection in it. So the ultrasound is extremely important in that. And in the first world countries, oftentimes here we do not use a CT scan, but in first world countries, almost everyone who's suspected of having acute appendicitis will have an abdominal CT scan with contrast. In our developing nation, we often do not do that because doing such a test each time can be very costly to the patient and also to the institution.
That was quite a mouthful of information. I'm happy to hear about those tests that can be carried out, because I think at times the diagnosis could present a bit of a challenge. Like you said, by the process of elimination, you can do your confirmation test. And that is what science is all about. It can be 5 possible things. You eliminated 3, you have 2 more. And especially if it is a female, my understanding is that it can be more challenging because the female tends to have more organs or systems on the right side of the body as compared to that of a male. Good information. I think we need to take a quick break and come back. For people who might be taking notes.
Welcome to the customer support portal, where we have made it easier for you to contact us. It starts with your question, email, a message, phone call, or a search on our website. Our CSP provides prompt and efficient solutions to your problems. We pride ourselves on treating our clients responsibly and ensuring your information is kept safe. Log on to www.skndb.net and send us a ticket or email us at customersupport@skndb.com. You may also call us directly at 869-465-2288, extension 1322, or 954-353-1003.
If you have a dream, what are you waiting for? The development bank has what you need and more. We aim to build stronger communities. That's why we have so many opportunities. Business loans, student loans, we make a positive difference in your life, in your life, in your life, in your life. Yeah, financing your dream home, we make a positive difference in your life, in your life, in your life, in your life. Yeah. Development Bank of St. Kitts and Nevis. We make a sustained positive difference in your life.
Fellow citizens, near and far, join Newrish Nital on Sugar Soda 90.3 for Fear No Favor.
Where is the cancer man? No runner come out for war.
Tune in to 90.3 on your FM dial. Log on to sugarcityfmsankits.com or download Simple Radio app from the Google Play Store. And join Newrish Nital every Thursday night from 8 to 10 p.m. as Newrish Nital tackles the issues and take your call. Fear No Favor. Every Thursday night from 8 to 10 p.m. on Sugar City 90.3 FM.
Welcome back to Fear No Favor with our surgeon, our general surgeon, Dr. Natalie Osborne. We would have been provided with some very valuable information thus far, and I know some of my listeners, they will be taking notes because they'd like to meet me later on and maybe indicate that they would have had a question, and whether or not they did not want to disrupt the smooth flow, or they attempted to get in and did not, they would still like to follow up the question. And that is okay, because from this program, if you have questions, you can WhatsApp me and I can forward them to the surgeon and she can provide me with an explanation that I may be able to forward to you. Because, you know, she's very busy and her phone number just cannot be out there because she is extremely busy doing a lot of stuff, and maybe at a convenient juncture, she can get the time to respond to somebody who might have had a question, a follow-up question from our show. Now, Doc, what is the treatment for appendicitis?
Okay, so once you've made your diagnosis, as we said earlier, with your signs and symptoms, your physical examination, assisted at times by your imaging study, we spoke about the ultrasound or CT scan in rare occasions, we will proceed with doing what we call an appendectomy. That is making an incision on the abdominal wall, entering the abdomen, locating the appendix, and removing it so that infectious process can be halted. That is a very common surgical procedure, actually the most common surgical procedure done worldwide, and appendectomy. Usually a very successful procedure with over 99% success rate, but however, sometimes there may be post-op complication. It is important to note that the earlier that the patient presents to the emergency room, the earlier the case is diagnosed, the better the outcome is. So early detection and early treatment leads to a better outcome.
And it is a surgical removal. What type do we normally use at our hospital? Is it the incision, or do you use equipment that you put inside to carry out the
Okay,
procedure for you?
I understand. The appendectomy can be done what we call open, which was the traditional way where you make an incision in the right lower quadrant. There's several different types of incision that you can make in the right lower quadrant, or it can be done laparoscopically, where you make several small incisions or cuts on the abdominal wall. You insert your instruments and you remove it. We do not perform the laparoscopic procedure here, as most our surgeons here are not technically prepared for that, and the resources and the limitations that we have. But we can, though, however, do it in a single incision and can make a very cosmetic incision, make it low enough so that you can cover it with your bikini or you can cover it with your underwear so that it's not seen. And that can be cosmetic as well. However, I must say that a laparoscopic procedure tends to give you, the post-op time of sick leave would usually be less. The person recovers quickly. The person can get back to work and get back to their normal lifestyle with a laparoscopic appendectomy. But we do not currently offer that here in the Federation.
How long would surgical procedure to remove an inflamed appendicitis last? About how long on average?
On average. To give a hard number would be unfair of me because every patient is different. You always have to take into consideration the time of diagnosis, because it's not the same if it is diagnosed early or it is diagnosed 3 or 4 days later. Do you understand? You always take into consideration the size of the patient. A patient with a flat abdomen who's much slender is not the same as someone who has a high body mass index. That person is a little bit heavier, on the heavier side. So that makes some difference. And the technical skill of the surgeon as well comes into play. So there are several factors. But if I want to force to say a timeline, you want to get it done within 45 minutes to an hour at best.
When someone would have taken the surgical procedure, how long do they take to leave the hospital? Do they go home right away? They put in overnight, 2 days, 3 days?
Okay. In certain institutions, not in ours, if the person has a laparoscopic appendectomy, the person can go home the next day, the very next day. Sometimes you observe the patient just overnight or 24 hours. In our case, where we do an open appendectomy, we usually observe the patient with a smooth recovery, because some patients' recovery time is different. Some patients may have some post-op complications or post-op delay in their progress. But that time can be within 3 to 4 days if the case progresses smoothly without any hiccups, as we say, or any complications.
Is there any particular type of food that a patient must not consume too soon after having that surgical procedure?
Once a patient has been operated, or any kind of operation on the abdomen is considered a major operation. So once you've had that operation, we like to reintroduce the diet very slowly, usually beginning with liquids, then soft diet. As we say, you may have some oatmeal, stuff like that, maybe a bit of mashed potato, and then you progress until the patient is comfortable enough to have a full diet. There is usually no specific limitations, but you want to introduce or reintroduce food slowly post-op. Why is that so? Because of the surgery, we can have, oftentimes the patient can have a post-op ileus. What does that mean? That the peristaltic waves or the movement in the gastrointestinal tract or in the bowels has slowed down because of the surgery, sometimes because of the anesthetic drugs that are used. And so you don't want to introduce food immediately after the surgery and cause the patient to vomit and cause the patient to have abdominal bloating or distension. So you usually want to wait for the patient to start passing gas, maybe stool. You introduce the diet slowly, beginning with liquid, soft, and then a full diet. But a particular limitation on the type of food, there isn't really such. A patient can always eat in moderation as he or she improves with the days.
Does it take a while for the patient to return to normal life, like exercising, going back to work?
Yes, it does. Because we are doing an open appendectomy, oftentimes the patient can have between 4 to 6 weeks post-op of sick leave time where you're encouraged to move around, do light activity, but you don't want to do anything that is physically strenuous. One of the most important thing we encourage our patients to avoid is physical activity, heavyweight lifting after. So you start to reintroduce your physical activity like your exercise, starting with walks. You could take some walks, but what we do not want you to do is to go into the gym and start doing push-ups and lifting heavy weights immediately after surgery. What you want to do is prevent having a post-op complication like a hernia at the incision site, because that can happen if not care is not taken.
Is it important to that the patient make sure that they keep the surgical site sterile, clean?
In the first days, we put a dressing on the wound, making sure that you keep it away from the environmental contaminations and stuff like that. When the nurses or the staff is doing the wound dressing, you make sure you ensure that it's done in a sterile manner. But as the days progresses and the wound seals, there is no outside contamination that can get in easily. At that point, the wound can be left open. So as we said, all of that is done in a particular manner with a particular time frame.
I know sometimes when you have a cut, you can put what we call stitches on the inside and then some on the outside. Would a surgical procedure for acute appendicitis fall into that category where you have to put both inside or outside?
Yes, as there are several layers to the abdominal wall, you have different muscles. So you have the skin on the outside, you have the fat layer, you have 3 major muscle groups that goes from the outside to the inside. And before you get inside the tummy, there's also another layer that's called the peritoneum. So there are several layers. And as you open these layers, when you're done, you have to close each layer as you come out in the same fashion in which you opened it. Okay, so there are always going to be the sutures on the inside, or stitches, as you said, and those on the outside. All right?
Do we use dissolvable sutures?
Yes. Most of the sutures for the acute appendicitis that are done on the inside are reabsorbable. Those, over time, they reabsorb. Your body tissue break them down, and then they dissolve, as we say.
Is there a real probability that someone might go against doctor's instruction and would have to be reopened in order to cure an area that was disrupted due to not paying attention to the instruction that were given?
What you speak of
Yes.
is what we call post-op complication. And it's not really fair to blame it directly on the patient. They're natural complications of just having a surgery, and they're complication of an acute appendicitis itself. So those are 2 different categories. Anytime that you operate or you cut into the abdomen or the body, it's an assault on the body. It's a trauma to the body, and you can have complication. The wound can become infected, which is one of the most common complications associated with acute appendicitis, as acute appendicitis itself is an infectious process. You can also have a hematoma. Sometimes there may be bleeding that is under the skin, leading to swelling and oozing of blood. You can have different things like a watery substance coming out, like bloody water, as we say. We call that like a seroma. So there are different complications. You want to encourage your patient, especially, to take it easy and slowly and gradually reincorporate into their activities. but there are surgical complications in any procedure, and is not necessarily the fault of the patient.
Okay, let us take a short break and come back.
Welcome to the Customer Support Portal, where we have made it easier for you to contact us. It starts with your question, email, a message, phone call, or a search on our website. Our CSP provides prompt and efficient solutions to your problems. We pride ourselves on treating our clients responsibly and ensuring your information is kept safe. Log on to www.skndb.net and send us a ticket or email us at customersupport@skndb.com. You may also call us directly at 869-465-2288, extension 1322, or 954-353-1003.
If you have a dream, what are you waiting for? The Development Bank has what you need and more. We aim to build stronger communities. That's why we have so many opportunities. Business loans, student loans, we make a positive difference in your life, in your life, in your life, in your life, yeah. Financing your dream home, we make a positive difference in your life, in your life, in your life, in your life, yeah. Development Bank of St. Kitts and Nevis. We make a sustained positive difference in your life.
Fellow citizens, near and far, join Newrish Nital on Sugar Soda 90.3 for Fear No Favor.
Where is man? Where is the cancer man? No runner come out for war.
Tune in to 90.3 on your FM dial. Log on to sugarcityfmsankits.com or download Simple Radio app from the Google Play Store. And join Newrish Nital every Thursday night from 8 to 10 p.m. as Newrish Nital tackles the issues and take your call. Fear No Favor. Every Thursday night from 8 to 10 p.m. on Sugar City 90.3 FM.
Would you stand up and see your country dying and never lend a helping hand? Would you see your children's future dwindling, creating much disillusion? Or would we watch on idly, disregarding our self-sufficiency? Administration, wrecking all I know. I said no, not that wrong. Citizens, let's unite and stand up for rights. All
Welcome to the Customer Support Portal, where we have made it easier for you to contact us. It starts with your question, email, a message, phone call, or a search on our website. Our CSP provides prompt and efficient solutions to your problems. We pride ourselves on treating our clients responsibly and ensuring your information is kept safe. Log on to www.skndb.net sknnews.net and send us a ticket or email us at customersupport@skndb.com. You may also call us directly at 869-465-2288, extension 1322 or 954-353-1003.
Welcome back to Fear in Our Favor with our surgeon, Dr. Natalie Osborne. Now, Doc, what happens in the event that simultaneously you have a pregnancy and at the same time the person is experiencing pain from an acute appendicitis?
Okay, that's an excellent question because we have a young population, our females. We have lots of women who come to the emergency room who are pregnant and have abdominal pain. It makes it much more complex. We spoke about differential diagnosis earlier, and one of the differential diagnoses could just be a normal intrauterine pregnancy. So as the uterus rises out of the pelvis, there's what we call the attachment, the round ligament, that can be stretched and that can give the woman pain. So it makes it so much more trickier for the woman with who's pregnant and having abdominal pain, because it can be a whole series of things. One of the things that may be distorted as the uterus grows with the developing fetus, it displaces the intestines, all of the bowels, also displaces the appendix. So instead of being down in the right lower quadrant, oftentimes the pain is higher up, or in the right upper quadrant, or higher up in the flank, because the organs and the structures are displaced. So that makes it a lot trickier. Also, in pregnancy, a woman often have nausea and vomits. And in appendicitis, there's nausea and vomits. So when you speak of the signs and symptoms, it can make it so much trickier. The woman can lose her appetite. She can have abdominal discomfort because the fetus and the uterus is pressing on her stomach as well too. So these are things. Also, she can have frequent urinary tract infection in the pregnancy. So that as well can compound the situation. And with a pregnancy, when you go and check the labs, a woman can have her white blood cells that we spoke about, which is an indicator that there may be an infection. She can have her white blood cells elevated. So it makes it so much more complicated. That is where an ultrasound would be very helpful in the case of this pregnancy, because what you want to be absolutely sure is that you're making a correct diagnosis of acute appendicitis, or else you can put the fetus at great risk, and we do not want to do that if it's not a true appendicitis and it may be just some pain or discomfort associated with her pregnancy. One of the things that we've learned with acute appendicitis over the years is that, which is very important for our public to know, is that the pain in acute appendicitis does not go away. It progressively becomes worse. So with time, it progresses. So it's not a pain that comes and goes. It is usually very constant, and it gets worse with time. When you have these females that present oftentimes with this pain that comes and goes or wax and wanes, it may not be an acute appendicitis, but it is still very difficult. So you want to keep these things in mind, and especially the gynecologist or the OBGYN who's managing the pregnancy would get the general surgeon involved, so there would be a collaboration to evaluate this patient. We can admit the patient and observe the patient, because as we said, acute appendicitis only worsens with time, and usually with the appendix, it reveals itself with appendicitis. So a tincture of time, we often said, is important. But the diagnosis is extremely difficult in pregnancy.
Does the appendix increase in volume when it is inflamed?
Yes. It increases in volume. Remember, we said the pathophysiology or the history behind it is an obstruction of the opening or the lumen. And once the opening is blocked off and the mucus and the secretion continue to come from the inner lining or the wall of the appendix, it becomes more and more distended. okay, and more engorged. And as it becomes more and more distended, then it can lead to perforation if it progresses like that. So yes, it can be increase in size, increase in volume.
What happens when an appendix ruptures in someone? They just didn't get a chance to go for the surgery before, they might have been late. Some people take painkillers, and as a result of that, they must subside the pain that you would normally associate with acute appendicitis. So once that pain is masked, there's a possibility that the appendix will be going through increased inflammation or inflaming and then just rupture.
Yes, excellent question. That's why we're here to inform the public that when you're having abdominal pain, you cannot just keep taking, or you should not just keep taking pain medication or analgesics because that can, mask the pain. But as we said, with acute appendicitis, the pain never really goes away. You have some relief for maybe a couple of hours, and then the pain returns. But if you realize that you've been taking analgesics or pain medication over a period of hours and your pain continues to worsen, it is best to seek medical attention. Because if the pain is allowed or left, some persons have a higher level or higher threshold of pain tolerance. So that person may be able to dismiss a pain more than someone else, and that person may present later. So if the patient presents and the appendix is perforated, it makes the treatment a little bit more complex, because what could have been a small incision in the right lower quadrant may turn into a major laparotomy, where you may have to make a big incision in the middle of the abdomen. So time loss can lead to more complication. It may turn an incision that could have been small and tiny into a major incision in the abdomen. So once you have a perforated appendix, it makes your case a lot more complex. The treatment is much more involved. Your stay in the hospital becomes much more prolonged as well too, and there are complications associated with that. We spoke about complications like after you've had surgery, you may have what we call a post-op ileus, where your bowel is not functioning as it should. You may have a long period where you have to stay. You may have a wound infection because of the severe perforation. You may even go on to have what we call a hernia, an incisional hernia. So these complications are worsened if the appendix perforates within the patient.
But if the appendix already ruptured, why do you still go in? Can't you just use antibiotics? Do you still have to go and remove the remnants? And while you're answering that, could you give us an idea, but on average, because people will differ, how big is that appendix? Like a little carrot? How big it is?
We said that the appendix is like a tube-like structure. I have a pen here, if those who are watching on the Facebook. It's a tube-like structure, very tiny. It's roughly the length of about 10 centimeters. Some persons may have it a little bit shorter, some persons a little bit longer. So that's the average size of it. Almost like, yes, the size of this pen that I have here in terms of the dimension, okay? So it's roughly between around 10 centimeters on average length, the appendix. So your question is, if the appendix ruptures inside of the patient, if you can just give antibiotics, that would not be correct in most cases. I will explain to you. There are different types of ways that the appendix can perforate. The appendix can, what we call, form a phlegmon or walled off. If there is a rupture of the appendix, the body is so smart and the immune system goes immediately in defense mode, where what we call different structures within the abdomen or within the tummy goes to that side to wall off the infection, so it can become localized. That we call a phlegmon, where the person they'll present with some symptoms of acute appendicitis, but when you examine them, you'll have a mass or swelling inside the abdomen in the right lower quadrant that is confirmed with a CT scan or ultrasound. In that instant, you can treat the patient with antibiotics, and later you're encouraged to go back in. Some authors recommend within 6 months and remove the appendix after the acute inflammation resolves and the Waldorf or the phlegmon resolves. However, if there is a free perforation, what do I mean by that? If the pus has spread all throughout the abdomen, that is a different story, and that patient can become very ill and develop what we call sepsis, where there is a generalized infection that gets into the bloodstream, and that is a very life-threatening condition. So that case, you'll have to intervene surgically. In some instances, if you are in a country where you can have access to interventional radiologists, you can have drains placed in, guided by CT scan or guided by ultrasound to drain out the pus. But in our instance, you will have to have a laparotomy as well. That's another option where the abdomen is open and you aspirate or remove the infectious process and clean out, or what we call do a toilet of the peritoneal cavity, and in that instance we leave several drains as well to drain any remaining pus. So they're two separate and distinct cases, but in most cases the definitive diagnosis, the definitive treatment is to do the appendectomy. Antibiotics alone usually does not solve the problem.
Interesting. Yeah, very interesting. Most persons would wonder, because I think that, you can, don't forget, if you're listening and you have a question, you can call in at 466-0903. We would be eager to have the good doctor address your questions or your concerns, because this is a very popular topic. I think I went to see a friend one time and the appendix would have ruptured and created some situation there at the hospital. But we have to know signs. Sometimes we take things for granted, and at least you can tell somebody, if your left side is hurting you, can you be absolutely certain that there might not be any impact of inflamed appendix?
Oh, very interesting question, and for you to ask that. In rare occasions, there are two things that may happen. Some persons, we said that the length of the appendix can vary. In rare occasions, the patient may have most of their pain on the left side because the appendix is so long, it stretches or reaches over on that side. And that is rare, but it can happen. And another instance is what we call situs inversus, where the person's organs are flipped. That also is very rare, but it can happen. So instead of on the left side, mostly the heart is projected more on the right side, and the other organs are flipped on the other side. And we had a case, a very interesting case like that many years ago, where the patient, we had to make our incision on the left side for the appendectomy. And sure enough, we found the appendix there because that person had what we call situs inversus. So our audience can look that up as well too. It's not a very common condition or abnormality, but it does happen. And in that instance, you may find the appendix on the opposite side. But usually, though, I just want to make sure it's the rear, and most times the cases follow the norm in this instance. So if you're having pain in your right lower quadrant, you want to ensure that it's not acute appendicitis or it's something else. So it is best that you follow up with your physician and get some medical attention. You were saying?
Where hernias are located, can they come up anywhere? Sometimes you find children boarding for the navel because they have maybe a hernia or something in that. Is it on the right-hand side, left-hand side, or it could be almost anywhere?
Well, hernias, we've gotten into the topic of hernias. That's something we could talk about in another session, but you asked about hernias. There are many different types of hernias, but the most common hernias are what we call umbilical hernia. You see that often in infants, young children, where there is a swelling and the bulge at the umbilicus. You can also often have hernias down in the groin, or just there, just where the thigh meets the hip region. We call that area the groin. You can have hernias there. Those are called inguinal hernias, not the common hernia. You could have a hernia just above the umbilicus. We call that a supraumbilical hernia. Or you could have hernias after an incision that you would have had, or surgery that you would have had. And we call that as incisional hernia. So you might have been operated for even your appendix, and you develop a bulge or swelling in that area. Or you might have been operated for your gallbladder or some other procedure, and then you develop a swelling and a bulge at the site.
Okay, thanks much. Now, sometimes persons visit the emergency room on several occasions and are sent home, later to be diagnosed with acute appendicitis. Is it because the patients are being misdiagnosed?
In that instant, we spoke earlier about the signs and symptoms, and I just want to reiterate that acute appendicitis is the most common surgical diagnosis. The diagnosis usually is clinical, based on the signs and symptoms, the physical findings, aided by laboratory results and stuff, but it's mostly a clinical diagnosis. Oftentimes with acute appendicitis in the early stage, the symptoms are vague. We said that the pain may begin around the navel. We call that the periumbilical region, or by the mouth of the stomach, where we call the epigastric region. The pain can present like that. And in the early instant, the patient may come and give you complaints of a bit of discomfort there, but it's very non-specific. They may say they feel nauseous, but they haven't vomited. They don't have any fever. And that person may be advised, usually, and I always do this, leaving the hospital does not mean that medical care ends. Walking out of the hospital does not mean that medical care ends. At that point, the emergency room physician may have, because I was one myself, may not have enough elements at that time to make the diagnosis of acute appendicitis. But we always encourage the patient to return to the emergency room, or to seek assistance if the pain worsens, or to even visit their private physician. So it is not just that they're being misdiagnosed, but it's a diagnosis that can be complex at times, and especially in a female who is in her reproductive age.
Is there mandatory after surgical procedure care? Does the surgeon instruct the patient to come back for a checkup? Because I guess one of the complexities, as you would have mentioned, could be infection at the site where the incision was made. Are they normally asked to come back within a week, 2 weeks, or even go to see the personal? Is it okay for them to go and see the personal doctor instead of coming back to see the surgeon?
Okay, I always encourage the patient to visit or follow up with the doctor who did the procedure. That it would be the best course of action, especially immediately. In general surgery, what we do, we follow up with the patient, and once you deem that the patient is fit, you can discharge the patient, and they can return to their regular physician, their family physician, or whoever. But if you're the surgeon who would have operated on that patient, you're more familiar with the case, you know exactly what you would have done, the type of sutures that you use, the complexity of the case, the condition of the appendix, or whatever organ or structure you would have operated on, and that's the best person to follow up with in the post-operative period, the immediate post-operative period. So, for example, I go and do an appendectomy tonight, and I discharge a patient Monday. It would not be the best advice for them to go and see their family physician down in Sandy Point, because the family physician would be unaware of what happened, how did the procedure go in that instant. So it's best to follow up with the surgeon who did the actual surgery.
When we have, just a little bit obliquely, when we have patients and we develop records, files, I don't know if it might be wiser. Could a patient ask for his or her file to be a part of his home environment? Could he get a copy of his file?
What we do, and that's most institutions do, you do not get a copy of the files. So it's not that we're going to take your files and send it to the secretary and have a copy everything and send it to you. What we do is give a summary of what has happened to you. And you're free to do that. The patient is encouraged to go to the hospital, and at the front desk with the receptionist, she can make that person makes a request, and there's a specific form that you fill to make that request. But we do not give the file itself and everything printed or copied. We give a summary of what would have taken place. So I have a typical patient, and they had a hernia done a year ago, and they want to go overseas, and they're requesting some medical attention. I would get the chart, look at the date, the time in the note of operation, and I'll make a summary of that, including the significant laboratory results and the findings, and I'll make a summary of that, and that I'll send off to the patient.
I have a sort of ticklish question. Now, you alluded to the fact that at times the diagnosis can be a bit of a challenge, so you got to go through a process of elimination and confirmation. Let us suppose even after doing all of that, none of us perfect, no output is perfect, and you reach inside, and then you realize, well, this appendix is intact. What do? Do you take it out since it would not be missed, or you just come back out without furthering your intention? How the surgeon thinks at that time? What would happen?
That's an excellent question, and I'm glad how your mind is thinking. And I'll tell you what, surgical scars tell a story, and it's important to understand that. And there, I said earlier, there's specific incisions that you make for the appendix. We call the common one that we do a Rocky Davis incision, because the two guys who named it were surnames, I think, Rocky and Davis. So it's Rocky Davis. There's another one who was, how should I say, originated under McBurney. So he got his name attached to that incision. So I said that to let you know that an incision tells a story. And once a patient has an incision on the abdomen, what if you had an appendectomy at 5, or you have an incision on your abdomen at 5, and now you're 56, and your mother and father, they're deceased, they're long gone, and you do not know what that incision is about? The surgeon himself or herself would be able to look at an incision and say, oh, that incision is indicative of an appendectomy. So I said that to say, if you go in and make that specific incision for an appendectomy and you find that the appendix is normal, you remove it. As we said, it's not an organ that you're going to miss. Because sometimes even when you're doing other procedures and the appendix is easily accessible, you can remove the appendix so the patient never comes back. We call that an incidental appendectomy. For example, someone is going in and they are working on the colon for another purpose, and the appendix is easily accessible, you can do an appendectomy. But all of that you'll have to make sure and explain to the patient clearly so they know that the appendix is no longer there. So I said this to say...
So you do that after to let them know it's not there? Don't you have to get the informed consent to say, well, you say you're going to remove it, but you say, having removed it, you'd have to inform the patient.
No,
but no, you don't have. Is it reversed? You don't have to inform the patient that you're going to remove it.
Sometimes that can be discussed. There's certain gynecological procedures that you're doing beforehand. You say, I'm going to do a hysterectomy, for example, and do you want the appendix taken out? And that can be organized and planned. So that's what we say, an incidental appendectomy. That can be thing. But we spoke about going in and not removing the appendix, but you have the scar. So once you're in, you usually remove the appendix. There's one condition, though, when you will not remove the appendix. It is called what we call a terminal ileitis, and I'll explain. Where there is inflammation there, it's also called what we know as Crohn's disease. If that disease affects the distal ileum or the small bowel and the cecum where the appendix is located, and all that area is inflamed, you would not want to do an appendectomy because what? You go and stitch or cut an inflamed part of the bowel, then you can have complication. You can have leakage. Your suture would not be able to stay. You can then create what we call a fistula or drain. So that's the only reason you would not remove the appendix. But once you make that incision that is indicative of an appendectomy, you remove the appendix so that many years from now, because the person may live until they're 90. What if they present then with abdominal pain right there? You can be comfortable and confident with that incision and that scar that is not the appendix.
But even with that situation and you leave the appendix there, isn't there a possibility that it can rupture and the inflammation can spread throughout the region now? You say it was heavily inflamed. The example that you gave, the hypothetical example. So why leave it when there's a real probability that it may rupture?
No, but remember we said it's a specific disease that is affecting it or that is affecting the surrounding bowels that is then affecting the appendix. That disease or that condition, Crohn's disease, can then be treated. So usually we're not trying to complicate it, but they're usually not going to give you an acute appendicitis at that instant, but that's the only medical situation or condition where you do not go and remove the appendix immediately. Because you're trying to avoid any complications that may have. Because if you go and you're working on a bowel that is inflamed, grossly inflamed, then you can have complications and that you want to avoid.
Let us take a break, acknowledge our sponsor, and come back.
Welcome to the customer support portal, where we have made it easier for you to contact us. It starts with your question, email, a message, phone call, or a search on our website. Our CSP provides prompt and efficient solutions to your problems. We pride ourselves on treating our clients responsibly and ensuring your information is kept safe. Log on to www.skndb.net and send us a ticket or email us at customersupport@skndb.com. You may also call us directly at 869-465-2288, extension 1322 or 954-353-1003.
If you have a dream, what are you waiting for? The development bank has what you need and more. We aim to build stronger communities. That's why we have so many opportunities. Business loans, student loans, we make a positive difference in your life, in your life, in your life, in your life. Yeah, financing your dream home, we make a positive difference in your life, in your life, in your life, in your life. Yeah. Development Bank of St. Kitts and Nevis. We make a sustained positive difference in your life.
Fellow citizens, near and far, join Newrish Nital on Sugar City 90.3 for Fear No Favor.
Where is the cancer man? No runner come out for war.
Tune in to 90.3 on your FM dial. Log on to sugarcityfmstkits.com or download Simple Radio app from the Google Play Store. And join Newrish Nital every Thursday night from 8 to 10 p.m. as Newrish Nital tackles the issues and take your call. Fear No Favor. Every Thursday night from 8 to 10 p.m. on Sugar City 90.3 FM.
Welcome back to Fear No Favor with our General Surgeon, Dr. Natalie Osborne. Now, when one is preparing, last week the last time you were here, we talked about preparation for surgery. If somebody is going to get a surgical procedure for an appendix removal, can they eat? Is there a particular period of time they must not eat before? What should we know?
Okay, if you're diagnosed with acute appendicitis, at that moment you're advised not to eat again. But remember, it's an emergency, so it is not a planned procedure. So the patient shows up in a private office or the patient shows up at the hospital. But luckily enough, with this diagnosis, you generally lose your appetite anyhow. So you're not going to be having a big meal. So you've lost your appetite. So you will say, Doc, I haven't eaten much for the last 2 days, So, but as it is not a planned surgery, if the patient would have eaten, right? And you have to do the procedure because whatever the procedure, if it's an emergency, a red emergency, you still would have to proceed. Oftentimes, you can wait a couple of hours. As in the instance of acute appendicitis, you may have some time that you can give the bowels or give the stomach a time to empty out 2 to 3 hours, 4 hours, and proceed with the case. Okay, because it is important in that instance to have the stomach empty so that the person, during the anesthesia, the person does not vomit and aspirate. We spoke about that. You don't want your patient to aspirate and have a lung infection later on.
Do you wait the 2 to 3 hours to facilitate natural progression of the food digestion and absorption, or do you induce the action of the person to go off instead of waiting?
No, there are mechanisms that we can do. In acute appendicitis, as well too, we can introduce what we call a nasogastric tube. You must have gone to the hospital and seen a friend with a tube going through his nose. And that tube enters into the stomach. That way you can evacuate the stomach as well too. But as I said, in an emergency situation, you will have to proceed and put in a nasogastric tube or NG tube, as we said, to help to decompress the abdomen. You can aspirate or remove some of the content during that time. But I'm simply saying the condition of the stomach does not necessarily hinder you in an emergency setting. You still have to proceed if it is a life or death procedure.
Duly noted. Will the appendix be missed after surgery?
No, the appendix, we said earlier, initially, the appendix doesn't have, from most literature, what most scientists and doctors believe doesn't have a function, and it can easily be removed and the person goes on to have a very normal life. So it is not an organ that will be missed.
We often hear that appendix can burst. What happens if it bursts inside a patient before surgery?
I think we discussed some of that earlier, if it were thing, but I could reiterate some of it. If it bursts inside of the surgery, inside of the patient before the surgery occurs, it complicates the case a little bit more, where you may have to turn what could have been a smaller incision into a much larger incision, where the person may have to spend a more prolonged time in the hospital to have full antibiotic coverage for a longer period of time. So yes, usually the outcome is still good. There are cases where the patient may go on to have meet his or her demise, which is not that common because acute appendicitis has a mortality rate that is very, very low. But usually it makes the case much more complex at that time, where you have prolonged stay in the hospital, longer period of time with antibiotics. You're at risk for post-operative infection and other complications. Yes. So it makes it more difficult.
What if someone goes to the hospital thinking that they have acute appendicitis, but are sent home?
Yes, and this is one of the take-home points we want to ensure that our listening audience have. and take with them that if you are sent home, do not be afraid to return the following day or return in a couple hours if the pain worsens. We said earlier that in the initial stage, the symptoms may be vague, and so then as the symptoms and the pain become more localized to the right lower quadrant, at that time you may be more, it may be, the diagnosis can be a lot clearer, so you can return without a hesitation. And we always advise patients to return if the symptoms worsen. I said earlier, discharge from the hospital doesn't mean discharge from care. Patients are always advised to follow up. The hospital is open 24/7, and there are quite a few physicians in the Federation who can assist you if you have any concerns and you need a second opinion. A second opinion is often encouraged if you're not comfortable with what you were told and you're convinced that something is wrong, because you know your body best, and the patient has to be their own advocate as well. So if you leave the institution and you're not comfortable with the response or the diagnosis that was made, you're free to return later on or to seek attention by another physician.
Very, very interesting. Now, returning, I want to ask a question that we might be able to quantify, maybe not, but we indicated earlier that there are different thresholds of pain tolerance. Different individuals have different thresholds. Let us suppose we're using a single individual with a categorized threshold for pain. How would the pain from acute appendicitis compare to kidney stones moving along the same person's bladder? Which one would be more intense? If you can only put a ballpark perception on it.
Yes. The pain can be described differently in medicine. A pain can be stabbing, a pain can be crampy, a pain can be throbbing, it can be sharp. In acute appendicitis, the pain is usually what we call insidious in its onset, and I'll tell you, it comes on slowly, and it builds up. But once it's there, it is constant. It doesn't wax or wane. It doesn't go or come. So that is something when you see your physician asking the patient, when did the pain begin? How would you describe the pain? Is the pain constant? Does it come and go? Has it been worsening over time? And we usually use a scale from 0 or 1 to 10, where 10 is the worst pain you've ever felt, and that is based on the individual, and 1 is a very minor pain. So you'll ask that patient, how was the pain when it first began, and how is it now? When you compare the pain with something like a kidney stone, the pain in the kidney stone is extremely sharp, extremely intense. The patient would say, the pain came on me suddenly and it was like a 10. So it doesn't really build up as much as the appendicitis. It is there, it is sharp. But what happens? It comes and goes. You can get some relief and it waxes and wanes. Not so with the acute appendicitis, And that pain that you have there with a kidney stone, for example, it radiates down to the genital region in both the females and male. And another thing that I've observed over time, and it is described that if you have that patient moving about and jerking about, that is terrible when you have a kidney stone. So for most of these diseases, as a physician, I learned very early on that if you take your time and do a good take a good history and physical, you can come to the diagnosis at least 90% of the time. And then you're using other 10% to use with your laboratory results as assisted by your imaging studies. But as we progress and technology progress, sometimes we're doing it the inverse. We want to go immediately to the studies. But if you sit and you speak with your patient and you get a good history, it can help you eliminate quite a bit because their description of these different types of pains.
let us suppose a hypothetical situation. Somebody is in pain, and is there a policy that you do not give painkillers to person at a particular time if they're complaining for a particular area or pain in a particular area? Because if you're going to ask them to describe the pain, but they're under mask conditions, is there a policy that even if you, because people when they go to the hospital and in pain, they expect to get something one time to alleviate the pain. Is that a practice? Should you really do that? Or should you let it play out a while with just maybe a moderate pain reliever? What do you do in that case?
So that is where your history taking, like you're interviewing a patient. The patient is there, you introduce yourself, you start taking some information from the patient, their age, stuff like that, if they have any other comorbidities, whatever, and you start to talk about the pain, they describe the pain. Whole lots of stuff you're asking when you're talking about pain. Describing the quality of the pain, the intensity of the pain, the duration of the pain, the location of the pain. If you do that and you have a history now and you've done your physical exam and you think that is an acute appendicitis and you've made your diagnosis and confirm and you said, yes, we're going to do the appendectomy at 10 a.m., but it's 8 a.m. right now and you cannot get in the operating room until 10 a.m. At that point, you can comfortably give your patient some pain reliever until you get to the operating room at 10 a.m. But until you've made your diagnosis, you do not want to mask the pain. Because, for example, in the emergency room, the doctors do a shift system. So you end your shift at 3 o'clock. The patient comes in and the pain is masked. When the physician who comes on at 3 and you've left, they may think, oh, this is not acute appendicitis. But you will have to document clearly that you gave the patient some pain medication. But in summary, in conclusion, until we are comfortable with the diagnosis, that we've ruled out the diagnosis of acute appendicitis or concluded that it is appendicitis, we do not want to give a pain medication. But if I'm going to operate on the patient, I could say, I'm sure I'm going to operate, but I want the patient to have a couple hours of pain-free. We can proceed with some pain medication because we know that we're going to go in and do an appendectomy.
Or sometimes the interview might not be well facilitated because the person is so much pain and all they're telling you that they're in pain, and they're not answering any questions.
In that instance at time, remember in our earlier bit in the discussion, we also stated that the pain in acute appendicitis does not disappear. So sometimes you give a pain reliever, some sort of analgesics, a couple hours, it is back on again. So that is also very helpful. So if you have the patient in intense pain and just writhing in pain and is unable to communicate because of the pain, in some instances you're allowed to give some pain medication, see if the patient can calm down and you can get a better detailed history. Okay, but usually we do not want to mask the pain or cover the pain up until we've made that diagnosis. But everything is not perfect.
Torture.
Everything is not perfect.
I understand. Give and take.
You have to give and take.
I understand. What are some of when you starting to deal with the patient, what are some of the popular painkillers you'd use to alleviate the pain of somebody who's really experienced excruciating pain? Once you would have already made your diagnosis.
We've got stuff like morphine, pethidine, just randomly saying the name, stuff like the NSAIDs group. We've got Voltaren. Most persons would have heard of that. Tramadol, stuff like that. You can also give Panadol or paracetamol, acetaminophen. It comes under different brand name. You can do that, give it oral or give it IV. But if the patient is in excruciating pain, you may want to give whatever medication you're giving, you want to give it IV or IM, which is intramuscular, or in the veins, which is IV.
But sometimes you ask a patient, are you allergic to morphine, for example? But they have never taken morphine before. You understand?
Yes.
So, but you feel like morphine might be the most ideal for that situation because a very strong painkiller. What do you do when you have not already established whether this person might have an allergic reaction to morphine?
Well, the same as with any antibiotics, any other drug. For the first time until a person uses a drug, they do not know they're allergic to the drug.
Right.
And then once you find that the person is allergic to the drug, they have some sort of reaction, you put measures in place to treat that because they're treatments for an allergic reaction, you know. So
And
that's what you do. But if you've never used a drug, you cannot tell that you're allergic to it unless you've used something similar or in the same family, which might have given you a reaction prior, and you want to be careful and not use that drug.
But would the surgeon or the doctor be aware of certain symptoms that might be allergic reactions?
Of course, the common symptoms are your skin start to itch, you get bumps and wales on your skin, your lips start to get swollen, your throat may start to get scratched, you start to close up in worst case scenario, your eyes becomes puffy, your face is all swollen. There are signs associated with it and symptoms.
Let us assume from a hypothetical situation that was the case. How do you go about ameliorating the condition of somebody who is now having a serious allergic reaction? Do you put in something to dilute the impact, or based on the strength that was administered, you say, okay, they'll get over that in the next 2 hours, 3 hours. But again, it might be serious to leave it for 2-3 hours. How do you negate?
But
Something
there are
like
drugs
that?
for that. We call them, most of them are like some form of antihistamines. You have the hydrocortisones, different groups and family groups. Common things we have at the hospital, Piriton, dexamethasone, different things like that, steroid group that would help with an allergic reaction. So treatment is there for any allergic reaction. And you can do that immediately and get effects from that. Your worst case scenario in allergic reaction is that the airway closes up. You may have to intubate that person immediately, things like that. But usually we can mitigate that and put treatment in place.
Have you performed an appendix surgical procedure on an appendix in recent time?
Yes. Yes, I have.
I know sometime as a surgeon and you're into stuff, there are some of them that you are awaiting.
Yes.
And you cannot wait to put your application. There's always a first in everything.
Yes.
There's always a first in everything.
Remember we said that's one of the most common, it is the most common surgical procedure, so it's seen quite often. And yes, we do it quite often here in the hospital. I remember as a trainee, that's one of the first case you want to get your hands on. You're salivating when you're in your first year of residency to get an appendix. You say, oh, I'm going up, I had my first appendectomy, and you're excited about that. But as your skills develop and you progress, of course, you want to do bigger cases. You want to do stuff that are more advanced. But we always say the appendix and the appendix because some person may come with an appendix that is so much more complex and another one can be so much easier, because there are variations in the anatomy. No one is absolutely equal. So there are different things like that. So some may be much easier, some be more complex. But as you progress in your years of service in your profession, of course, you get excited about doing some cases more than others, and you want to do something at times more complex, to practice your skills and to grow technically.
Okay. Let us take a break, acknowledge our sponsor. Basically,
Welcome to the Customer Support Portal, where we have made it easier for you to contact us. It starts with your question, email, a message, phone call, or a search on our website. Our CSP provides prompt and efficient solutions to your problems. We pride ourselves on treating our clients responsibly and ensuring your information is kept safe. Log on to www.skndb.net and send us a ticket or email us at customersupport@skndb.com. You may also call us directly at 869-465-2288, extension 1322 or 954-353-1003.
If you have a dream, what are you waiting for? The development bank has what you need and more. We aim to build stronger communities. That's why we have so many opportunities. Business loans, student loans, we make a positive difference in your life, in your life, in your life, in your life. Yeah, financing your dream home, we make a positive difference in your life, in your life, in your life, in your life. Yeah. Development Bank of St. Kitts and Nevis. We make a sustained positive difference in your life.
Fellow citizens, near and far, join Newrish Nital on Sugar City 90.3 for Fear Nor Favor.
Where is the cancer man? No runner come out for war.
Tune in to 90.3 on your FM dial. Log on to sugarcityfmsankits.com or download Simple Radio app from the Google Play Store. And join Newrish Nital every Thursday night from 8 to 10 p.m. as Newrish Nital tackles the issues and take your call. Fear Nor Favor every Thursday night from 8 to 10 p.m. on Sugar City 90.3 FM.
Welcome back to Fear Nor Favor, and every good thing must come to an end. Initially, we intended to have this particular part of the program for about an hour, but then so much information was naturally flowing that we managed to go down to an hour, 37 minutes. And it is time for the good doctor to leave her parting words with us, encouragement, signs to look out for, those sort of stuff. So we listen to her for the next 2 or 3 minutes, and then she would have to go and perform her duties, and then I will just continue for the next 15 minutes. So over to you, Dr. Osborne.
Okay. Anything, whenever I do something, presentation, or discussion with students, my single objective is that you leave knowing a little bit than whence you first came. That is always what I say to the students. You want to leave having a little bit more knowledge. And I would hope that in this discussion that you were able to understand and be a bit wiser in terms of your diagnosis of acute appendicitis. So my parting words would be just to remind you, acute appendicitis can happen in any age group, but it's usually around the age of 10 to 30. The adolescents and the young adults tend to have acute appendicitis more frequently, but you can see it in the older population. Just about a week and a half ago, we had a patient who was 65 who was diagnosed with acute appendicitis. So there is no absolute. What I want you to keep in mind, though, once you have any abdominal pain, starting in the periumbilical region around your navel, and then localizing itself in your right lower quadrant, or really down by your hip region, going down that area, you want to be acutely aware. And if you start having any nausea, if you're vomiting, you want to keep acute appendicitis in mind. And never be afraid to visit the doctor. Never be afraid to visit the hospital. And if you're not comfortable, you can return again. Because what we do not want is to have our patients coming in late and being diagnosed late and having quite a bit of complications associated with delayed diagnosis, where you can have a more complicated outcome. So my take home is that remember the signs that we discuss here this evening. You can go over the presentation. Your abdominal pain that starts around the navel goes to your right lower quadrant, your nausea, vomits, fever, chills. You can have loss of appetite as well. You can have diarrhea, bloating. And if you ask a friend or you touch your right side and you find that it's quite tender there, you want to make sure that you see a doctor and get a proper workup so that we can make a diagnosis, whether it is acute appendicitis or whatever the diagnosis. So I'm thankful for you giving me the time that you've heard me, and I hope that everything that I would have said, if you don't remember all, that you've kept some of the most salient information at heart so that you can put it into practice. You may not only be able to save your own life, you may be able to save a friend or family with this information. So I want to thank you, Mr. Nital, for having me here this evening on your program, and thanks to the listening audience for paying such keen attention. So have a good night.
Yes, and those are her parting shots. We'll take a break and permit her to get herself together and journey to her home away from home. Okay.
Welcome to the Customer Support Portal, where we have made it easier for you to contact us. It starts with your question, email, a message, phone call, or a search on our website. Our CSP provides prompt and efficient solutions to your problems. We pride ourselves on treating our clients responsibly and ensuring your information is kept safe. Log on to www.skndb.net and send us a ticket or email us at customersupport@skndb.com. You may also call us directly at 869-465-2288, extension 1322, or 954-353-1003.
If you have a dream, what are you waiting for? The development bank has what you need and more. We aim to build stronger communities. That's why we have so many opportunities. Bank of St. Kitts and Nevis. We make a sustained positive difference in your life.
Fellow citizens, near and far, join Newrish Nital on Sugar Soda 90.3 for Fear No Favor.
Where is man? Where is the cancer man? No runner come out for war.
Tune in to 90.3 on your FM dial. Log on to sugarcityfmsankits.com or download Simple Radio app from the Google Play Store. And join Newrish Nital every Thursday night from 8 to 10 p.m. as Newrish Nital tackles the issues and take your call. Fear No Favor. Every Thursday night from 8 to 10 p.m. on Sugar City 90.3 FM.
of this case. Reunification, building a brand new nation. We move on together hand in hand. So rise, citizens, arise. The country is yours, all yours, still yours.
Welcome back to Fear in Our Favor, and I would really like to say a special thank you to our General Surgeon, Dr. Natalie Osborne, for taking the time out of her extremely busy schedule to be here with us to share information, because appendicitis is something that impacts a lot of people globally, and it is one of the most common surgical procedure that we or the surgeon at the hospital would execute. And it is nice to get information, because sometimes we do not even know which side, if our side is hurting us, what signs to look for. And since that we are now better informed, we can ask our family members, friends, to describe what they are feeling, where they are feeling that particular pain. And I have come to realize that it is important for persons to be able to describe the type of pain that they are experiencing. And maybe sometimes we can bring some various description of the different types of pain so people can understand. Because if you go to a doctor's office, or you go to the health center, you go to the clinic, they have to ask the questions before they can do anything. You just cannot go up the hospital and stand up and say, look after me. Look after you. What is happening to you? So we have to create a culture where persons would be able to describe what they are feeling, what they are experiencing, and for what period of time, where it happens, and when it is happening more intensely, whether the pain would have gone away and then came back. We have to, as a culture, there are better things for us to do than to get down each other's throats. We can help persons to diagnose situations and present themselves for help as quickly as possible, because certain things cannot be delayed. You have to teach your children how to describe pain. How to describe pain. And nothing wrong with that. We can start in our homes. You can start out with about just 3 different types, and then you go in between and you fill it out and you ask questions. Is it moving? Is it one area? But how would you describe the intensity? Because that too can help in the diagnosis when you go to the hospital or to a doctor's office. So I'm very happy that we did that, and we're actually starting a series. We're hoping that it can happen every 2 weeks and deal with different topics, but of course it will be within the surgical context. But still, a surgeon is a doctor as well, and there might be things that the good surgeon would be able to adjust for us. Certain things are just a common thread amongst doctors of different specialities, and they too can provide question and guidance going forward. I always thought about this. As a matter of fact, I used to do this when I did Frank and Candid at ZIZ. Used to do it on a very frequent basis with Dr. Wilkinson, our medical chief of staff. And I think that we would have done about 2, 3 programs down at Sugar City. I think I did one with him alone and maybe 2 or 3 with both of them. So she has been in his company, accompanying him both in the operation room and on various missions to educate our population. And it is good to know that she would have taken that advanced step, and any one of you can feel extremely confident that the young lady, I mean, you say young, sometimes young and experienced would not always go hand in hand, but she has been doing this thing for about 16 years and is now general surgeon for 4 going on 5 years. So we want to wish her well. We want to encourage her. And with the mood of the land and the landscape changing every so often, I think they could anticipate, because there's an actual real probability that they might be called upon to do more work. We like to appeal to the general public, in as much as it is practically possible, try to give our doctors less unnecessary work. Already they are overwhelmed with persons who are suffering or ailing or sick from certain conditions, and I don't think it would be fair for them to have to sacrifice and choose, because every life is important. I can recall when Dr. Wilkinson used to be under a lot of pressure for a period of time. He was the main person and the only person operating on these guys when they had gunshot wounds, stabbing, chopping up, all sort of stuff. We cannot afford to return to those situations. Cannot afford to do that. We have to be more considerate of each other. And as such, we have to start somewhere. We need a circuit breaker. We cannot continue. We cannot go back up by the 30-something. The year has just started. And already in the Federation, we have about 3. 1, 2, 3, no. About 4. And I think that is a good amount per capita for a small population-sized federation as ours. So each one of us will play our role and try to discourage that particular type of behavior. But I always say that it starts in our homes. I made a post and I indicated that we have a lot of houses, but very little homes. Yes, our government would have promised that they would build 2,000 new houses, but then how do we construct homes? It is okay. Give people work, labor costs, material, everything, and we put up some houses. But how do we convert those houses upon completion into homes? Homes is pivotal for our survival as a society. Too many houses and too little homes. We need that transformation. Every one of us has a part to play in that. But charity, the education, the transformation, the instructive nature of the communication must start at home. Must start at home. Or preferably must have less houses and more homes. Cause people to stay home in an environment where they can be under control and they can be given sound, solid advice so that they make more judicious decisions. And we can be a better place. So tourism is the backbone of our economy. And if that perception, our image becomes tarnished, most likely we can lose persons coming to our shores. Not only on the cruise ships, but our stayovers might not be at the level that we would like them to be. So we have to create that environment that will be conducive for them to not only visit by cruise ship, but to stay over. We have to. If we do not do that, then quite a number of persons will not be able to experience 4 square meals. There will no longer be 4 sides. You might go down to a triangular meal, only 3, because then we will not be able to generate the revenue that would be necessary as a result of persons not coming. And not only the tourists may not come, but foreign investment is key to our further development. And investors do not go to shores where there is such great extent of instability. Social stability is key to attract investors. When you have the social stability, then you can start thinking about possible touristic products and capital projects. But it wouldn't come if the environment is not conducive. So to be forewarned is to be forearmed. I have issued my utterance, and I hope you in your own personal home and space can do likewise and encourage our young men in particular, and not to get the idea that females are not included. So I want you to encourage our young men and women to help us to produce a more conducive federation for foreign investment and tourist visit. Thank you very much. We have come to the end of the program. I would like to thank those of you who listened, and I would like to again reiterate my thanks to Dr. Natalie Osborne, our general surgeon at our hospital, and everybody else who made the show what it turned out to be, and to our sponsors, the Development Bank, for the continued supply of oxygen for the sustenance of this all-important social program. Thank you.
The opinions and statements made by the host and participants in this program are not those of the